Welcome back to the Deep Dive.
Great to be here.
Today we're diving into a condition tied very closely to a specific line of work, Coal Workers Pneumoconiosis, CWP for short.
A significant occupational lung disease.
Yeah, exactly. Okay, let's unpack this. We'll cover what it actually is, what causes it, how doctors spot it, and importantly, what can be done about it.
Right. We're drawing on the latest revision notes, aiming for a clear picture.
Think of it as the essential info you need on CWP.
Absolutely. So pneumoconiosis itself is kind of an umbrella term, right, for lung diseases caused by inhaling various dusts that just sit there.
Okay.
And CWP is the big one, the most common, specifically from coal dust getting trapped in the lungs.
So when that coal dust gets in, what's it actually doing to the lungs?
Well, over time, it leads to these things called coal macules, basically small dark spots. You can also get slightly larger ones, nodules. And this whole process, it triggers fibrosis, that's scarring, essentially, in the lung tissue.
Scarring, right, which makes breathing harder, I assume.
Exactly. It impairs lung function. And a key thing here is the time lag. It can take many, many years after you stop being exposed for CWP to actually show up.
That's quite something. And it's officially recognized, isn't it?
It is. CWP is a notifiable disease, meaning cases have to be reported, and it's also a prescribed industrial disease.
Which means compensation might be possible.
Precisely. Because it's directly linked to work exposure. And there are two main types we talk about.
Okay.
There's simple CWP, which is mostly those coal macules we mentioned. And then there's complicated CWP, which involves progressive massive fibrosis, or PMF, much more severe scarring.
Got it. So cause-wise, it seems straightforward coal dust. But dig into that a bit.
Sure. The root cause is prolonged inhalation of coal dust. Think coal mining, obviously, but also related jobs where dust is kicked up.
Right.
The mechanism is you breathe it in, the tiny particles settle deep down in your lungs and the alveoli. They just accumulate.
And the body tries to fight back.
Yeah, your immune system reacts, causing inflammation. But because the dust doesn't go away, the inflammation becomes chronic. Long-term. And that's what eventually leads to the fibrosis, the scarring.
So the amount of exposure matters hugely.
Definitely. How long you were exposed and how much dust was in the air, the intensity, it's a direct relationship. More dust, more time, generally equals higher risk and potentially worse disease.
Makes sense. So main risk is obviously working in those environments. Are there other factors that, nudge the risk up or down?
Yeah, while the occupational exposure is paramount, other things contribute. We mentioned duration and intensity already. The actual properties of the dust, like particle size, can play a role. Smoking is a big one. It seems to worsen the lung damage from the dust.
Okay.
And if someone already has respiratory issues, they might be more susceptible. But yeah, the bottom line, coal miners, workers handling coal, processing it, they're the high-risk group.
Okay, let's zoom right in. Pathophysiology. What's happening on that tiny cellular level inside the lungs?
So, you breathe in the dust. These immune cells in your lung sacs, the alveolar macrophages, their job is to clean things up. They engulf the dust particles.
Trying to get rid of them.
Exactly. But with coal dust, especially over long periods, they can't really break it down or remove it effectively. They get overwhelmed. And these overloaded macrophages, they release inflammatory signals, chemical mediators. This keeps that inflammation cycle going.
Right, the chronic inflammation you mentioned.
Yes. And you get this buildup of dust-laden macrophages in the lung tissue. This whole process, this chronic battle, is what drives the fibrosis, the scarring.
And that forms the macrophiles and nodules.
Precisely. Those are basically collections of these macrophages and scarred tissue. And that physical scarring is what stiffens the lungs and makes it harder to breathe, causing the symptoms.
Okay. So if someone comes in coughing, short of breath, history of mining, CWP is high on the list.
Yeah.
But what else needs to be considered? The differential diagnosis.
Good point. You absolutely have to think about other things that look similar, especially other dust diseases. Silicosis, from silica dust, think construction, quarrying. Right. Asbestosis from asbestos exposure, both have occupational links too. And then there's the broader category of interstitial lung diseases, conditions that cause lung scarring but might have different causes altogether. So a really detailed exposure history covering all jobs, hobbies even, is critical to tell them apart.
Gotcha. How common is CWP now, particularly here in the UK, epidemiology-wise?
Well, the good news is that the prevalence, the number of people living with it, has dropped quite a bit in the UK.
Why is that?
mainly down to much better dust control measures and safety regulations in the mining industry over the years. Plus, of course, the massive decline of the coal industry itself since the mid-20th century means far fewer people are being exposed now.
But we still see cases.
Oh, yes. Particularly in older individuals who had heavy exposure back in the day, often concentrated in those traditional mining regions, and new diagnoses still happen.
Do we have any recent figures?
Yeah, just for context, asbestos-related diseases are still a major issue, causing many deaths. But for pneumoconiosis specifically, the figures for 2021 showed about 110 new cases of CWP assessed for benefits, and around 25 for silicosis.
Okay.
And it's also worth remembering the strong link between coal mining and COPD, chronic obstructive pulmonary disease. That accounts for a lot of occupational respiratory deaths each year, too.
Right. So let's talk about how it presents. What symptoms and signs would make you suspect CWP?
Often it starts subtly. A chronic cough, maybe producing phlegm. Shortness of breath is a big one, especially when exerting yourself.
Like walking uphill.
Exactly. Or just doing daily activities becomes harder. Wheezing, a feeling of tightness in the chest, those are common too. General decreased exercise tolerance.
And what might a doctor find on examination?
Listening to the lungs, they might hear abnormal sounds, maybe crackles or wheezes. Chest tightness might be apparent. Sometimes breath sounds may be quieter in certain areas. In more advanced, severe cases, you could see cyanosis, that bluish tinge to the skin, or lips from low oxygen, or even clubbing of the fingers, though that's less common than in some other lung diseases.
And it can get really serious.
Yes, it can progress to respiratory failure in severe forms. Also, people with CWP tend to be more susceptible to chest infections, and things like exertion or breathing and irritants can make their symptoms flare up. But the key is, it varies a lot based on severity.
So suspicion is high.
Yeah.
How do you confirm the diagnosis? What investigations are done?
It's usually a combination approach. Imaging is crucial. A chest x-ray or often a CT scan, particularly a high-resolution CT or HRCT, is very good at showing those characteristic changes.
The coal macules and nodules.
Yes, those small opacities, the nodules and signs of fibrosis or scarring. Then lung function tests spirometry, measuring diffusion capacity, DLCO, are vital. They tell you how much the lungs are impaired.
Okay.
But underpinning all of this is the occupational history. You need that detailed history of coal dust exposure. Without that link, the diagnosis is much harder.
So it's putting the pieces together: work history, symptoms, imaging, lung function.
Exactly. Sometimes, rarely, a lung biopsy might be needed if the picture isn't clear, but often the combination is enough.
Right. Now, management. Once CWP is diagnosed, what's the plan?
Well, the tough part is there's no cure. You can't reverse the fibrosis. So the absolute first step is stopping any further exposure. Get away from the dust.
Prevention of worsening.
Totally. That means strict engineering controls in workplaces if exposure is ongoing, and absolutely consistent use of appropriate personal protective equipment like respirators.
And for the symptoms people already have.
It's about managing those. Medications to help with breathlessness or cough, pulmonary rehabilitation programs to improve exercise tolerance and quality of life, treating any infections promptly.
Is specialist referral needed?
Often, yes. Especially for moderate to severe cases, or if complications arise like that PMF we mentioned, referral to a respiratory specialist or even a multidisciplinary team is common.
You mentioned general principles for industrial dust diseases.
Yeah, that's important context. For any suspected dust disease, you need a super thorough occupational history lifelong, including any dusty hobbies.
Right.
Diagnosis usually involves imaging like CXR or HRCT and lung function tests. Imaging alone isn't always enough. Seeing a chest physician is standard practice.
And the legal side?
That's a factor too. There can be financial compensation, tribunals, the need for expert medical opinions. It varies. Even with things like pleural plaques from asbestos, the legal implications differ across the UK nations.
And because it's incurable.
The focus shifts heavily to supportive care. Absolutely crucial is smoking cessation. It makes a huge difference. Managing symptoms effectively, sometimes palliative care if it's very advanced, and providing support, social, occupational, legal for patients and their families is vital. It's a lot to deal with.
Definitely. What about the long-term outlook, the prognosis?
It's quite variable. It really depends on how much exposure they had, for how long, whether they smoke, and if they develop complications like PMF.
Can progression be slowed?
Yes. Early detection, completely stopping exposure, and good symptom management can definitely help slow things down. But in severe cases, especially with PMF, it can lead to significant progressive respiratory impairment and a need for long-term oxygen or other support.
Which highlights prevention again.
Absolutely. Surveillance of workers, monitoring dust levels, proper ventilation in workplaces, dust suppression techniques, and, as we said, consistent use of face masks or respirators. Prevention is truly key.
Here's where it gets really interesting. Those complications. You mentioned PMF.
Yes, progressive massive fibrosis. This is where large masses of dense scar tissue, usually bigger than a centimeter, form in the lungs, often in the upper parts.
And that's bad news for lung function.
Very bad. PMF significantly worsens lung function, distorts the lung structure, and dramatically increases the risk of respiratory failure and complications like recurrent infections.
Are there other complications besides PMF?
People with CWP also seem to have an increased risk of developing chronic bronchitis and emphysema, which fall under that COPD umbrella we mentioned earlier, so multiple lung issues can coexist.
So what does this all mean? Let's wrap up the key takeaways on coal workers' pneumoconiosis.
Okay, so CWP is a lung disease caused by inhaling coal dust over long periods. It leads to inflammation and irreversible scarring fibrosis in the lungs.
And diagnosis hinges on that occupational exposure history, combined with characteristic imaging findings and lung function tests.
Exactly. There's no cure, so management focuses on preventing any further dust exposure and treating the symptoms to maintain quality of life. Stopping smoking is critical.
Early detection and those preventative measures in workplaces are paramount to try and slow down the disease progression.
Definitely. It's a stark reminder, really, of how occupational exposures can have profound and lasting effects on respiratory health, sometimes appearing many years later.
A really important topic. And for anyone wanting to dive deeper or revise this for exams, you can find more resources over at PathophysiologyBreakdown and freemsra.com. Good resources there.
Thanks for joining us on The Deep Dive.